Welcome to Happiness Isn't Brain Surgery with Doc Snipes. This podcast was created to provide you the information and tools Doc Snipes gives her clients so that you too can start living happier. Our website, DocSnipes.com, has even more resources, videos, and handouts, and even interactive sessions with Doc Snipes to help you apply what you learn. Go to DocSnipes.com to learn more. I'd like to welcome everybody to Happiness Isn't Brain Surgery with Doc Snipes. Today, we're going to continue talking about causes of depressive symptoms and ways to address them. In this section, we're going to review the causes, consequences, and possible interventions for lack of motivation and apathy. Now, these are symptoms that are common to a lot of things, and you may not be depressed, but you may just have one of those days or weeks where you're just like, I just don't care. I'm feeling blah about everything. And I often tell people, think about Eeyore from Winnie the Pooh. He was kind of apathetic and just went along, not a whole lot of motivation. This is kind of what I'm talking about here. So whether you're depressed or not, if you're experiencing a lack of motivation and apathy, we may have some tips for you here. Apathy is defined as a lack of motivation due to a lack of energy and or a lack of pleasure or reward. So you just don't care. It's like, whatever, I have no desire. Motivation is a feeling that can best be described as a desire to get up and go. So if you've got motivation, then you don't have apathy. They're kind of flip sides. You cannot get motivated without being able to experience pleasure or reward. When you do something, there's a reward for it. That's basic behavior modification. We do the things that have the most reward available to them. So when we're talking about increasing motivation, when we're talking about getting up and doing something, we're talking about what's the reward. We're going to choose the best option. I'm sitting on the couch, I'm watching a Netflix marathon, and I'm looking around going, you know what, I really need to mop the floors. What do you think I'm most motivated to do? Where's the reward? Watching the Netflix marathon or mopping the floors? Fortunately or unfortunately, in my case, it's mopping the floors because I'm a freak about floors. But you're going to choose the one that's probably most rewarding. So if you've got to do something that's not too rewarding, you're going to have to figure out how to make it rewarding. And I do have some tips for you there. Dopamine, norepinephrine, and serotonin are all involved in pleasure and reward. So if they're out of whack, then you're probably going to have difficulty feeling motivated and experiencing reward for things. Now, dopamine, for example, is and serotonin are prominently manipulated when somebody takes opiates. So it's not just depression. It could be a medication side effect that's causing lack of motivation and apathy. After the dopamine system kind of gets out of whack, if you don't have that substance in there to keep the levels up, then you may not feel quite so good. An imbalance between any of these three chemicals is believed to contribute to the lack of ability to feel reward or pleasure, which is why a lot of people return or relapse or reuse certain drugs, because they're not feeling, their neurochemicals are out of whack, and without that drug, they're not feeling happiness and reward. Imbalances can be caused by addictive behaviors. And I say that really generally. We're talking about everything from sex addiction to opiate use. Anything that causes a rush that gives you an extreme sense of pleasure, that's letting the dopamine floodgates open, which means your body has to make more and rebalance everything. And there's a whole presentation on what happens in addictive behaviors with your neurotransmitters. Just be aware that addictive behaviors of any kind can cause an imbalance in your neurochemicals. Now, the good thing is, after a period of not engaging in those behaviors, your brain chemicals generally balance back out to what they should be for you. Now, whether that's normal or happy, I can't say. Now, some people started using because they were self-medicating because their brain just didn't make enough of certain neurochemicals. And if that's you, then after your brain balances back out to where it should be, then you can start finding ways, working with your psychiatrist or your doctor, to get those neurotransmitter levels where they should be. But we can't tell anything until after your brain has recovered from being exposed to addictive behaviors. Chronic stress, mental or physical, also alters your neurochemical balance. Remember, I talked earlier about how serotonin goes down in the presence of cortisol. So understanding that if you're under chronic stress, and it can be physical as well as mental, if you're in pain all the time, it's going to be hard to feel pleasure. And most people can think back to a time when they were mentally stressed or when they were physically sick or in pain, and then you can go, yeah, it was real difficult to find anything really enjoyable at that point in time. So the whys are less important than understanding that that's what happens. Lack of quality sleep causes neurotransmitters to get out of balance. Poor nutrition. Your body makes neurotransmitters and recovers and repairs from the food you eat. If it doesn't have enough building blocks, you're probably not going to feel optimal. And hormone imbalances. As we age, as we get sick, when we take certain medications, your hormones can get out of whack. So it's important to pay attention to that as a possible cause of apathy and lack of get up and go, if you will. The nice thing is hormones can be measured in most hormones can be measured in blood tests. So that's something your doctor can easily look at and go, yes, there's a problem, or no, there's not. Your thyroid hormone is one of the ones that's easiest to test for. So if you're hypothyroid, you're probably not going to have a lot of get up and go. So let's talk about motivation killers here. There's 10 of them. Lack of purpose. If you're getting up and you just don't see the point to doing something, you're not going to have a lot of motivation. So it's important to identify those people, things, and goals which are important to you. And whenever you're getting ready to do something, go, okay, how is this helping me get closer to the people, things, and goals that are important to me? And once you identify that, you're going to be like, okay, it's worth getting up and working on. Poor diet. Make sure you're eating a healthy diet, including adequate water. If you don't have enough water, you're going to feel foggy, fatigued, exhausted. And regardless of anything else, when you're feeling that way, when you're feeling sluggish, your motivation generally will wane. You want to get quality proteins because those are the building blocks your body needs, and good sources of B vitamins and magnesium. Why B vitamins and magnesium? Because they're needed for the chemical reactions that break down the proteins to make the neurochemicals and the hormones you need to keep going. Vitamins are basically your body's little spark plugs. Think about trying to start a lawnmower, and you've got great gas in the lawnmower. The lawnmower itself, pretty functional. You go to start it and it just won't turn over because the spark plug is not there, or because the spark plug is dead. Well, the same sort of thing happens in your body. If you're not providing it, the proteins are like the gas and the vitamins are like the spark plug. So you can have great proteins in there, but if you're not getting a good balance of vitamins, your engine ain't going to go. Quality sleep. I know we went over this last time. We're going to spend a little time here. I use the acronym SHADES. This might help you remember it. S stands for have a sleep routine, an hour and a half before bed, to help cue your body it's about time to go to sleep. H stands for hydration. Reduce it 3 hours before bed so you don't have to get up and go pee throughout the night. A stands for alcohol. Avoid it. You want to make sure that your blood alcohol is 0.000 at bedtime, so you're not processing alcohol when you're trying to go to sleep. D stands for darkness. Use blue light filters on any of your electronic devices to help you get to sleep. If you have a television on when you're going to sleep, then make sure to set the sleep timer so it goes off, shortly after you drift off, so that's not interrupting your sleep. E stands for ergonomics. Have a good pillow and a good mattress so you're not waking up with a sore shoulder or a crooked neck. And S stands for stimulants. Avoid them. Cut back on your caffeine. make sure you cut back on your if you use any nicotine products 2 hours before bedtime, and be aware that decongestants are stimulants and will impact your sleep if you have to take them, but you want to try to avoid anything that's a stimulant several hours before bed. Other motivation killers include being overwhelmed. You need to prioritize. Make a list of everything you got to do. And I say got to do because most of us think we got to do everything. Then you want to prioritize the must-dos from the can-waits. And, I have a list of got to do's a mile long, but there's probably only about 15 of them that I have to do, or there's going to be significant negative consequences. The rest of them are can-waits, as energy allows. Make a list of the things on your must-do list and try doing one thing a day. Start knocking them off one at a time instead of going, well, I've got to get all this done this weekend. Identify 2 or 3 things, and then next weekend, 2 or 3 more things. Ask for help and delegate things that can be delegated. You can mark some things off your list by having the kids help out, your neighbor, your spouse, best friend, whatever. Simplify. Some things don't have to take a bunch of time. If you normally spend an hour and a half cooking dinner every night, well, that's wonderful. But if you are short on time and you are overwhelmed, meals can be simplified. There are what are those things called? Frozen dinners that you can put in. You can order out. Do you want to do that every single night? No, probably not. But can you simplify if there's a week where you just feel like you've got 16 million things going on? Sure. Cleaning's the same way. Yes, ideally you would dust and vacuum and mop and do all those things on a regular basis. But in the big scheme of things, if you are pinched for time, what has to be done in your mind as far as cleaning goes? And leave it at that. If you can skip laundry for a week, then maybe you can. Set and maintain boundaries with other people. A lot of times we get feeling overwhelmed because we've said yes to too many people. Somebody asks us to do something and we say yes, and we have a bunch of other stuff going on, but we don't want to bother anybody by asking for help. One of the important things in health and happiness is finding balance, being able to say no and being okay with that. And if you can't, look at the reasons why. Are you afraid of rejection? That might be something else you need to deal with. Obviously, you don't want to say no in a mean way, but being able to say no and stick to your guns and say, no, I've really got too much going on right now. Maybe next week or 2 weeks from now, we can set a time to go out and hang out or something. Setting and maintain boundaries is really important to keeping from being overwhelmed. The other part of that is being able to ask for help. When you've got too much on your plate, being able to go to one of your friends and say, I really need assistance with this. Would you be willing? And they can say yes or no, but those boundaries are there to help you know what you can and can't do and know when you need help. If you set boundaries that tell you that, when it gets to this point, I really need to reach out, that's going to help you be happier and healthier. Circadian rhythm disruption is also another motivation killer. Aim for 5 to 10 minutes of sunlight in the morning and evening. A lot of us get this going to and from our car, but if you don't, maybe you can sit by a bright window when you're drinking your coffee in the morning. Ideally out on the patio, but you don't have to be in bright sunlight. Obviously, you don't really want to do it between the hours of 10 a.m. and 4 p.m. when the UV is the strongest. But you do want to get bright light that cues your body that, hey, it's morning, and throughout the day, so your body knows that it's time to be awake. Keep a similar daily schedule, and during dark weeks or seasons, use daylight bulbs at least 14 hours a day. And like I said in the other presentation, daylight bulbs are not the same as light therapy, but they will help if you use the broad spectrum daylight bulbs and keep it bright in your environment about 14 hours a day. Another motivation killer is a lack of reward. Some goals are long haul. It's not something that's going to be fixed in a week. Depression recovery, going on a diet, anger management. Those are all things that are probably going to take several weeks or even a couple of months to really see significant improvement. If you don't get a reward until several weeks or several months down the road, you're probably not going to stay motivated to keep working on it. So identify daily and weekly sub goals that you can give yourself credit for. So for example, in depression recovery, if you go an entire day without crying, that might be a big milestone for you. So give yourself some sort of a reward. Note the small steps, note the small progress that you've got going to keep yourself moving forward. Don't take for granted a job well done either. So if it's something that's long haul, like depression recovery or getting in shape, don't do it and go, well, that's what I was supposed to do. Do it and look back at it and go, I did that. Give yourself credit for making progress. Give yourself credit for how hard it is to actually change a way of thinking or a way of acting or a way of being that has characterized you for quite a while. So give yourself credit for, and even for the small things like mopping the floor. Look at it and go, that looks good. Instead of, got that done, moving on to the next thing. Positive rewards. Too often, even with other people, the only time we say something is when it's negative. We don't give positive feedback unsolicited. We don't walk in and go, hey, you did a really good job getting your chores done today. I know I try to do that more with my teenagers when I come home. Instead of just taking for granted that, yep, they did their chores, I try to make sure that I give them positive feedback so they know that I noticed and they know that I recognize that it took effort for them to do their chores. If you have a lack of get up and go, one thing that I learned when I was working on my dissertation was the principle of do 15. Sometimes it's really, really overwhelming to get started. But if you think, you know what, I can do anything for 15 minutes. So I would get on the computer and I would say, I'm going to work on this for 15 minutes. And after 15 minutes, if I'm still miserable, then I will do something else. I can't think of a single time that I got on the computer to do 15 and got off after 15 minutes. Usually once I got started, it wasn't so bad. It was just getting up and getting started. So the do 15 principle helps. Pair it with something else, like watching TV. When I fold laundry, I watch TV. When my son was little, and even sometimes now, when I'm doing it without my son, but we made a game out of it. We would pair socks and we would have buckets for everybody's socks and we would see who could make the most baskets. And it was a game. I have horrible aim. So it's always, a reward if I actually make it into the bucket. Little mind games that you can play with yourself can make it more interesting or amusing. Call a friend. If it's something you can do and talk to a friend at the same time, sometimes that makes it go faster. Or listen to music. Put on your headphones and just rock out while you're doing whatever it is. Misery loves company. And, you wouldn't think this would go into motivation killers. But if you've got something that you've got to do, like maybe you don't want to go to the gym. You hate going to the gym, but you really want to get in better shape. If you can find somebody else who's a friend that wants to go to the gym with you, whether they love it or hate it, it doesn't really matter. The two of you can go together, and it's easier to do something that you don't want to do if you've got some social support doing it. It's one of the reasons I go to the gym. I like being surrounded by other people that are pushing themselves. Congratulate yourself and appreciate the work when it's done. So just like I said before, whatever you're doing, instead of going, all right, got the laundry done, moving on to the next task, when you're finished, look at it and go, wow, I just did 4 loads of laundry. Good for me. Time for a break. Congratulate yourself. Give yourself a little 15-minute break and then move on to the next task. Another motivation killer is fear of failure. So what does failure mean to you? If you fail, why is that a big deal? Some people look at failure as an opportunity to learn. Other people look at failure as a mark against them. So what does failure mean to you and about you? Once you figure that out, then you can start addressing it. What do you do when you fail? So if you go out and you try a new project and you fail miserably at it, do you feel embarrassed, or do you go, well, I still have a lot more to learn, and you go back to the drawing board? Find a failure/success mantra. If you go online, you can Google this and come up with a bunch of them from really famous people. If you haven't failed, you haven't tried is one of my favorite, because a lot of times failure means we're getting outside of our comfort zone. We're getting outside of doing the things that we know how to do and do well, and we're trying something new. And it means it's okay to not get it on the first time. We've got to figure out, come back, regroup, and start again. It doesn't necessarily mean anything bad about us. In some cases, it means that we were courageous enough to try something that we weren't guaranteed on getting correct the first time. Another motivation killer is a lack of attention to your temperament. Extroverts prefer active environments. So if you're doing something and you're by yourself all the time and you're an extrovert, you're probably going to quickly lose motivation. When I used to study, I'm an extrovert. I would prefer to go either to a coffee shop and study or to the library. Now, I'm not talking to people, but I'm around other people, and there's hustle and bustle and energy. Those are the environments that I thrive in, and I was more motivated to study in those environments. Introverts, on the other hand, just want a block of uninterrupted time where they can sit and be alone for 4 hours or however long it is to do their thing, and then they can come out. So an introvert is not going to be motivated to go to the library where there's going to be interruptions and chaos. Sensors want widgets. Sensors want things that they can move around. They want facts, they want details. Anything that's big picture or broad is not going to be real motivating for them because they want something they can manipulate. Intuitors, on the other hand, need to see the big picture. So we need to see, why is it that we're doing this again? So I can do the small detail stuff if I can see the big picture. I can see the light at the end of the tunnel. I'm an intuitor. I'm not big on those small details. I would rather not deal with them, but I can get motivated to work with them if I can see the goal. I can see what's at the end. Thinkers need to know why it's important and necessary. Remember, they tend to go from a good-bad lens. Where feelers need to know how it will help harmonize people. How will it help everybody else be happier? How will this work to helping me be happier? Judgers need structure and planning. So if you're working in an environment where it's very spontaneous, judgers are going to get worn out and stressed out really easily, and it's going to be hard for them to get motivated. Perceivers, on the other hand, need flexibility and work best with a deadline because they can get a little too loosey-goosey. But if they have too much structure, they're not going to be motivated because they're going to feel like they're being, suffocated. They're going to feel stuck and not have the room to kind of spread their wings and be spontaneous. So going back to either Keirsey.com and doing the Keirsey temperament sorter, or going back to the presentation I did on strengths, needs, attitudes, preferences, and temperament, figure out what temperament dimensions you align with most closely and pay attention to those. If you feel a lack of motivation, go, what is it that I need to help get me excited or get me more motivated to keep going on this particular goal or activity? Chronic stress, it kills motivation. So you want to empty your trunk. Guilt and resentment, you can't change the past. It happened. So holding on to that, carrying it around like, 2 50-pound bags of dog food in your trunk, it's going to really weigh on your gas mileage. You want to get that stuff out of your trunk. Figure out how to deal with it. Develop a healthy support system. We all face stress. Like I said earlier, there are inevitable stressors. Healthy support systems are there to lend a hand, or at least emotional support, during those periods of stress and those things that are just unavoidable. And pick your battles. We can get caught up too often getting upset and angry over things that really have no consequence to us. And the little image here is the little dog from dog from Up, and he says, I've just met you and this is crazy, and he's getting ready to pour his heart out to this guy, which is important for him to nurture that relationship, but then he sees a squirrel and he gets all distracted. When we are under chronic stress, when we don't pick our battles, it's too easy to get distracted by every shiny thing that goes by or every irritant that goes by. We want to be able to say, you know what, not worth my energy. I want to use my energy over here. You need energy to be motivated. You need energy for get up and go. So pick your battles. Lack of motivation and apathy is called by an imbalance in neurotransmitters, which can be caused by a lack of purpose, poor nutrition, poor sleep, poor time management, circadian rhythm disruption, lack of reward, lack of get up and go, fear of failure, not paying attention to your temperament, and chronic stress. So there's a lot of stuff that you can start looking at before you even start thinking about, maybe I'm biologically, something's going wrong. Look at all these other things and see what sort of lifestyle factors are contributing. Now, you may not have a natural ideal balance of neurotransmitters or certain hormones, and your physician can help with that. But 80% of people in the US have lifestyle factors that are contributing to their imbalance of neurochemicals. So look and figure out which lifestyle factors you have that you can address. Pick one at a time. Start addressing it. And remember, improvement in one area is going to produce improvement in every other area, most likely. If you like this podcast, you can subscribe on your favorite podcast app. You can join our Facebook group at docsnipes.com/Facebook, or join our community and access additional resources at docsnipes.com. Good morning, and welcome to the class on the neurobiology of dopamine, GABA, serotonin, and acetylcholine. Sadly enough, this is one of my favorite topics, so hopefully you'll enjoy the hour as much as I will. Over the next hour, we're going to define neurobiology. And for the following neurotransmitters, we will look at their mechanism of action, their purpose, what they do in the brain and in the body, where they're found, because not all of them are found just in the brain. Symptoms of excess and insufficiency. We'll also talk about nutritional building blocks that our clients need to be ingesting so their bodies can make these neurotransmitters, and medications that are commonly used to affect these neurotransmitters. So what is neurobiology? Basically, it's the study of the brain and the nervous system, which generates sensation, perception, movement, learning, emotion, and many of the functions that make us human. As we talk about these few neurotransmitters, and there's a bunch more, but we're just talking about a select few today, you will figure out that they are involved in all of these things. So it's not just mood. These neurotransmitters are involved in pain reception, movement, motivation, learning, ability to focus attention. One of the things I want you to think about as we're talking is I want you to think about your patients, because too often we think, okay, somebody's depressed, it must be a serotonin deficiency. And that's not always the case. A lot of these neurotransmitters, when they are out of balance, either too much or too little, will create mood-related disorders and symptoms that mimic depression and anxiety. It's really important that we stress to our clients, especially if they're just starting to take medications, that it's an imperfect science, and sometimes we need to take a look at what's going on with them, their symptoms. We'll try something. If it has no effect, then we may try something completely different. And it's important for them to communicate with their physicians or their prescribing physician. I've always had the luxury of working in a clinic where we had an attending, and we would have case conferences with the physician and the client, so it was a great multidisciplinary team. Not everybody has that luxury. But it is important for clients to be able to communicate what their symptoms are and advocate for themselves. So dopamine, we're going to start out with the big one. Dopamine is the one that we really talk about in terms of reward and motivation. It's our pleasure chemical. But it is responsible for movement, memory, pleasurable reward, behavior and cognition, attention, inhibition of prolactin production, sleep, mood, and learning. So how can dopamine be involved in all that? Well, obviously there are a lot of complex mechanisms, but dopamine, remember I've said previously that we do things that are rewarding and we don't do things that are punishing or not rewarding. So dopamine is responsible for saying, yes, let's do that again. Yes, let's focus on this. Yes, let's pay attention here. Yes, let's focus here. So when somebody is doing something that is positive for them, or seems to be positive for them, the dopamine will reinforce that behavior and say, let's do that again. So dopamine is responsible for our eating behaviors. When we eat, a little bit of dopamine is released. Not a lot. We're not talking like a cocaine response. We're talking just a little bit, enough to say, this is pretty good. So let's go on and look at this a little bit further. Altered dopamine neurotransmission is implicated in cognitive control. So somebody has racing thoughts, has difficulty focusing, has difficulty paying attention, impulse control, and difficulty with their working memory. So basically a lot of the symptoms of ADHD. We want to look at what's going on with the dopamine system there. And I say altered because it can be too much or too little. The brain wants to keep a balance of all of these neurotransmitters. They work in concert. So if you have too much or too little, it's going to exacerbate or inhibit some of the others. That'll be clearer as we talk. So where do we find dopamine? We don't want to have racing thoughts. We don't want to have attention problems. We want to be motivated. We want to learn. We want to sleep. So where do we find this, and how do we make sure it's at its optimal levels? Ideally, the person, the body, is able to create enough dopamine to maintain its natural optimal level. Now, that can be disrupted when somebody's been basically abusing the dopamine system through addictive behaviors. And it is sometimes just a biological insufficiency. But for the majority of people out there, the body can maintain its proper level of dopamine if it has proper nutrition, proper rest, and the motivation is there. So the precursor is L-Dopa, which is synthesized in the brain and kidneys. Dopamine functions in several parts of the peripheral nervous system. So this is things other than the brain. In blood vessels, it inhibits norepinephrine release and acts as a vasodilator. It causes relaxation. Norepinephrine is one of your stimulant chemicals. So dopamine comes in there and goes, chill, just chill. In the kidneys, it increases sodium and urine excretion. Okay, this is important because the kidneys help balance that sodium-potassium levels in the body. So if it's increasing the sodium and urine excretion, then the person can get dehydrated, which can lead to feelings of depression. If the sodium and potassium levels get out of balance, they can have irregular heartbeats, tachycardia, things like that. So it's important to remember too much dopamine can cause problems. When we have patients who are abusing drugs that greatly increase dopamine, guess what? Their urine excretion is probably going to be a lot higher, and their electrolytes are probably going to be out of balance, which sets them up to be at higher risk for cardiac problems, sets them up to be at higher risk for panic attacks and things like that. In the pancreas, dopamine reduces insulin production. Okay, now think. We have a client who is abusing the dopamine system. Maybe they are porn addicted. Okay, we're not even talking cocaine here. We're talking porn addiction. And they are getting that dopamine rush 10, 15, 20 times a day. So they're getting more dopamine than their brain is really meant to handle. They're overloading that. So the pancreas may reduce insulin production as a result of, having too much dopamine in the system. Now, eventually, the brain's going to cut it back and say, all right, that's not the amount we're supposed to have. But if you've got a patient who's diabetic, you can see where addictive behaviors can exacerbate the diabetic symptomatology. In the digestive system, it reduces gastrointestinal motility and protects the intestinal mucosa, which is a fancy way for saying it keeps your belly happy. Again, if you've got somebody who is flooding their system with dopamine, they may find that they don't have a lot of gastrointestinal motility, and they may have some digestive problems. In the immune system, it reduces lymphocyte activity, tells the immune system to kind of chill out, which potentially, I don't know of any studies that have done this, but you can extrapolate that if you're reducing the lymphocyte activity, if you're reducing those white blood cells from doing their job, your immune system could go down. So all of these things are reasons we want to protect this dopamine system, aside from the fact that when it's either has insufficient dopamine or not enough is getting to the receiving neurons, that we start feeling depressed and lack motivation. Dopamine's a biggie. We want to cherish this. Symptoms of excess and insufficiency: excess dopamine, unnecessary movements and repetitive tics, psychosis, hypersexuality, nausea. Most antipsychotic drugs are dopamine antagonists. So if you have a client who is experiencing psychotic symptoms, one of the first things you're going to probably see the psychiatrist do is put them on an antipsychotic or an atypical antipsychotic. These are probably dopamine antagonists. They're probably there to reduce the amount of dopamine, which, in theory, you're going, okay, cool. It fixes them. Not exactly. We also see in people with bipolar disorder, which is why a lot of the atypical antipsychotics also are effective with people with bipolar disorder, the hypersexuality. And sometimes in a manic episode, there are some psychotic symptoms. So dopamine can be involved in a lot of different diagnoses. Dopamine antagonists are some of the most effective anti-nausea agents. Okay, great. Why do we care? Well, if you've got somebody who's on a dopamine antagonist, an antipsychotic drug, and they're also taking anti-nausea, they're basically kind of doubling up on their meds. One of the things that I've seen a lot over the many, many years is that patients don't effectively communicate with their doctors what medications they're taking. So you may have a patient seeing a psychiatrist and getting an antipsychotic, and you may have them seeing their general physician and getting an anti-nausea agent, and both doctors are prescribing dopamine antagonists, but guess what? Neither one of them knows about the other. So this person is actually getting too much of the dopamine antagonism. Insufficient dopamine. Negative symptoms of schizophrenia. And, just to kind of review Psych 101, negative symptoms are the things that we see in patients with schizophrenia that should be there. They don't want to talk. They are catatonic, cognitive deficits. So insufficient dopamine may lead to some of the negative symptoms of schizophrenia, which means we want to crank up the dopamine. So wait a minute. We have somebody with schizophrenia and we're prescribing antipsychotics or antipsychotic drugs, dopamine antagonists, that's the word I'm looking for. They're being prescribed an antagonist, but then they also have the negative symptoms. And so do we prescribe an agonist? So they're taking an agonist and an antagonist. It seems like it would cancel out, which it actually does usually. Insufficient dopamine is also implicated in a more acute sense of pain, Parkinson's disease, restless leg syndrome, and attention deficit hyperactivity disorder. Now, I had a client who had restless legs syndrome and was being prescribed medication for that. to increase her dopamine, but she was also displaying psychotic symptoms and symptoms of schizophrenia. So the psychiatrist was prescribing her, you guessed it, dopamine antagonists. So she was taking medications that were basically working against each other. Neurological symptoms that increase in frequency with age, such as decreased arm swing and increased muscle rigidity, and age-related changes in cognitive flexibility that we see in people as just a normal matter of course, can be because of the reduction of the dopamine receptors. Does that mean they all need to be medicated? No. But we do need to be more attentive to it and realize that dopamine may be implicated, and at some point they may need medication. Insufficient dopamine has also been implicated, and these will sound familiar to you, in lack of motivation, fatigue, inability to feel pleasure, sleep problems, sense of hopelessness, difficulty concentrating. Sound like the symptoms of depression? Yeah, it certainly does. So when we hear these symptoms, we don't want to automatically say it's this. It could be hypothyroid. It could be a dopamine imbalance. It could be a serotonin imbalance. It could be a host of things. So we need to not just jump at the first sign of depressive symptoms and go, oh, I know what's causing this, because we really don't. We're inaccurate at best. We found that there is about 40% of people, according to a recent Yale study, about 40% of people with depression, major clinical depression, that do not respond to SSRIs. Why is that? Because it's not working on the right serotonin receptors? Probably not. It's probably because their depressive symptoms are being caused by an imbalance in a different neurotransmitter. They're hypothesizing at this point dopamine or norepinephrine. But the link to that article is at the end of this presentation. If you want to go read up on it, it's actually a really well-written article. Nutritional building blocks for dopamine. Now, the cool thing is, with nutritional building blocks, as opposed to taking mega supplements or medications, the body's going to use what it needs, and it's going to, excrete the rest. So if we can encourage people to eat a healthy diet, the chances of them grossly throwing one neurotransmitter system or one system out of whack is highly unlikely. They're not going to eat, 4 cups of turmeric or 5 watermelons in a day. I don't even know if that would be enough. But eating a diet high in magnesium and tyrosine, and again, the tendency for a lot of our patients is to go, oh, high magnesium, well, let me go OD on magnesium supplements. And that's just dangerous in so many different ways. They want to eat a diet high in magnesium and tyrosine-rich foods to provide the basic building blocks. The other thing to educate your patients about, and we can't usually, in most states, I think all, but most states at least, we can't prescribe nutritional guidelines. That's something for a physician or a registered dietitian. But we can't educate our patients that the way foods occur in nature actually make them more available to our body. So if you just take a magnesium supplement, it may not be taken in but as well by the body as eating foods that are high in magnesium, which are also high in other vitamins that make it more bioavailable. List of foods known to increase dopamine. A lot of these are very palatable foods: chicken, almonds, apples, bananas. Bananas and chicken and almonds are actually 3 big ones that are common among all the neurotransmitters, but green leafy vegetables too. 2 of my favorites, chocolate and green tea, lima beans, oatmeal, wheat germ, sesame and pumpkin seeds, turmeric, and watermelon. I think I read those off in order of my preferences, but you can see that regardless of whether your patient is a vegan, a vegetarian, an omnivore, whatever, they can probably find some foods in this list that are supportive of healthy brain chemistry. encourage them before they start making major changes in their diet. Legal caveat here, encourage them to talk with their doctor and or a nutritionist first. Medications. Dopamine in the blood is unable to cross the blood-brain barrier to reach the brain. So we can't just give somebody dopamine and go, voila, you're going to have more dopamine and be better. What they do is they give a combination of levodopa and carbidopa, which actually the carbidopa prevents the levodopa from breaking down in the bloodstream before it gets to the brain. So it's more available once it gets to the brain. So in order to increase dopamine, we've got the levodopa-carbidopa combination. And it's actually kind of fun to say, but anyway, I digress. When we start looking at the dopamine antagonists, we've got risperidone, Haldol, and Zyprexa. A lot of others too, but these are the ones that in my practice I most commonly see. You can go to I think it's drugs.com, and you can find a list of all the common dopamine antagonists. Metoclopramide or Reglan is an antiemetic and an antipsychotic. It's given, I know my son was actually given it when he was discharged from the NICU because it helped with stomach emptying. Had I realized at that point that it acted on the dopamine system, I probably would have been much more resistant to giving it to him. Live and learn. But some of our patients may be experiencing, especially if they've got gastric reflux or something, may have this medication. So if they're taking Reglan in addition to risperidone, Haldol, Zyprexa, not all of those, obviously, any of those, again, they may be doubling up. Likewise, if you have a client who's taking an antagonist, but also has Parkinson's symptoms or restless legs, and they're taking something like Mirapex or Requip, and yes, I'm using the trade names just because that's what we usually recognize more easily. I'm not recommending or showing favoritism towards any of these. They're just the ones that I see more often in practice. You can see if they're taking one of those drugs plus an antagonist, they may be kind of working against each other. Patients with schizophrenia. Let's talk about the dopamine hypothesis that said dopamine imbalance causes schizophrenia. Not so much. We're figuring out that that was wrong, or at least a very crude hypothesis. Patients with schizophrenia don't typically show measurably increased levels of brain dopamine activity. Okay, so they don't have too much by measure, and they also don't have too little by measure. It's give or take within average, so we don't know exactly. Additionally, other dissociative drugs such as ketamine and phencyclidine that act on your glutamate receptors, we're going to talk about that when we get down to GABA, can also produce psychotic symptoms. So if there are other receptors that produce psychotic symptoms, we don't necessarily know that every patient that presents with psychotic symptoms has a dopamine imbalance. It could be an imbalance in glutamate or other receptors that we haven't identified yet. So those drugs that do reduce dopamine activity are a very imperfect treatment for schizophrenia. Not only do they only reduce the positive symptoms, they also may produce severe short and long-term effects. So we're just going to jump from that to GABA. Dopamine is our pleasure chemical. It's our reward chemical. GABA is our relaxation chemical, if we want to just kind of use a gross overview. It's generally used for anti-anxiety and anticonvulsant purposes. The interesting thing with GABA is that it's made from glutamate. So GABA functions as an inhibitory neurotransmitter, where glutamate, the precursor to GABA, is an excitatory neurotransmitter. So you need glutamate in order to form GABA, but they actually have opposite effects. Close to 40% of the synapses in the human brain work with GABA and therefore have GABA receptors. So we can see that for whatever reason, and I'm sure we haven't identified all of them yet. GABA is a really important neurotransmitter. Symptoms of excessive sleepiness, shallow breathing, basically getting way too relaxed, and symptoms of CNS depression. The interesting thing with GABA is that you have sort of a protective effect. If you get way too much, the blood pressure may go back up in order to try to self-protect. Symptoms of insufficiency: anxiety, depression, difficulty concentrating, insomnia, and sometimes seizure disorders. Nutritional building blocks: fermented foods like sauerkraut and yogurt, almonds again, cherry tomatoes, bananas again, oats again, lentils, brown rice, potatoes. Vitamin B6 is also important in the production of GABA. So making sure that your clients are getting, their servings of grains, where they're going to get their B vitamins from, is going to be important. Encourage them to educate themselves about what they're eating at the very least. Inositol is also a nutrient that is found in wheat germ, brown rice, green leafy vegetables, nuts, and beans. Same kind of list again. That is important in enabling the body to use GABA. So we want to make sure they're getting those, I don't want to say carbohydrates, because there's carbohydrates in everything. We want to make sure they're getting their grains, their nuts, and their grains. Medications: drugs that act as allosteric modulators of GABA receptors, or GABAergic drugs, increase the available amount of GABA and typically have a relaxing, anti-anxiety, and anti-convulsive effect. So you probably have worked with a client who's been on Neurontin or gabapentin. It's a GABA analog used to treat epilepsy and pain, especially with fibromyalgia. And I have one client who had a double mastectomy, and she still has some neurologic pain, and gabapentin has helped her with that. Your benzos and your barbiturates, including GHB, also can be used as GABAergic drugs. Serotonin, mechanisms of purpose. This is another one like dopamine that just does so many things, and too much or too little can be bad. Both cases bad. It helps regulate mood, your sleep patterns, appetite, and pain. We'll get to mood in a second, but one of the interesting things to understand about sleep patterns is melatonin comes from serotonin. Melatonin helps us sleep and relax at night. So if somebody is deficient in serotonin, guess what? Where is it found? It's found in the brain, but interestingly, the majority of your serotonin is found in your gut and in your intestines. So what does that say for people who have irritable bowel syndrome, Crohn's disease, yada, yada, yada? How does that impact their serotonin availability? I'm just postulating there. You can chew on that and think about it. Symptoms of excess serotonin. Now, I'm not talking serotonin syndrome, which is a life-threatening situation. If somebody is showing severe shivering, diarrhea, muscle rigidity, fever, seizures, and irregular heartbeat, it is a medical emergency. They need to get to the doctor, to the hospital right now. We're not going to the average doctor. Serotonin syndrome can be brought on by people taking multiple SSRIs, or sometimes the combination of certain other drugs. And again, drugs.com is great because it's got a interactions checker. You can put in the patient's medications, and then you can run a check, and it tells you which ones have been known to cause problems together. Does it mean they're never prescribed together? No. but it means there have been some negative reactions. If you have a patient who is just starting to take SSRIs, they may experience 1 or 2 mild symptoms. Generally, diarrhea is a big complaint when people start taking serotonin and kind of feeling lightheaded. That's the serotonin, the SSRI kind of getting into the system. But muscle rigidity, fevers with serotonin syndrome, the fever will go like way high, like cook you from the inside high. So it's important, again, to get people to the doctor. Oh, the other thing that can cause it is people are taking over-the-counter supplements that increase serotonin, like SAMe or 5-HTP. So if you've got them taking that plus SSRIs, they're setting themselves up for potentially a physical crisis. Other symptoms of excess: depression, apathy, emotional flatness, passivity, insomnia, difficulty concentrating, poor memory, difficulty making decisions and acting on them, and sexual dysfunction. And you're saying to yourself, that's the symptom of insufficiency. Well, yeah. Interestingly, too little or too much can basically produce very similar symptoms. One difference is when there is too much serotonin, we tend to find that person is a lot more anxious. They tend to be a lot more high strung, a lot more amped up. Does that always mean if somebody is depressed and anxious at the same time that they've got too much serotonin? No, it doesn't. We can't ever say anything is always with a person, but we can say that we need to look at whether increasing their serotonin is probably the best step, and talk with them more about their symptoms, how they came on, family history, those sorts of things. Insufficiency, depression, anxiety, and pain sensitivity. People with low serotonin have a higher pain sensitivity or a lower pain tolerance in general. We want to look at our patients who are in methadone clinics. As they are detoxing off of the methadone, we want to look and say, okay, well, they're not producing the endogenous opioids right now. We know that. But is their serotonin system also wonky as they're detoxing? Because, the detox from methadone, Suboxone, or any of your opiates is unpleasant at best. So other things may be getting out of whack, including their serotonin system, which, in addition to not having their natural painkillers, if their serotonin is out of whack, they may be more sensitive to that pain. Something to consider, something to look at if you've got a patient who is at risk of relapse, who is detoxing from opioids. Have them talk with their doctor. Nutritional building blocks. I'm going to sound like a broken record here. Whole wheat, potatoes, brown rice, lentils, oats, and beans. I told you it was a pretty short list that was just going to repeat, which is good, because you know what? A short list is easy for people to remember, and most people can find something on here that they like. Medications to adjust serotonin. Your SSRIs, your selective serotonin reuptake inhibitors, make sure that there's more serotonin in the synaptic space to get absorbed. Your SNRIs also work selectively on some of your serotonin receptors. SNRIs is selective norepinephrine reuptake inhibitors. 5-HTP, I mentioned that earlier. That is an over-the-counter supplement that is supposed to increase, and studies have shown it does increase levels of serotonin in certain people. Now, if they already have too much serotonin, whether or not they're taking SSRIs, this could further influence or make their problem worse. I really discourage my patients from just randomly taking supplements, especially ones that are purported to affect their mental health without talking to their doctor first and being medically supervised, because it is so easy to create a situation that is where they bring on a psychotic crisis, or they bring on a physical crisis. And finally, acetylcholine. Acetylcholine is one of those interesting ones that we don't talk about a lot. In lower amounts, acetylcholine can act as a stimulant. It causes the body to release norepinephrine and dopamine. So I'm thinking, ooh, I want more acetylcholine, so I get more dopamine. Doesn't exactly work that way, because remember I said they all work in concert and in balance. Acetylcholine is implicated in memory, motivation, higher order thought processes, sexual desire and activity, and sleep, just like all the others. Symptoms of excess, and I just shortened this because pretty much the entire DSM list of depressive symptoms was a symptom of excess acetylcholine. Nightmares, especially vivid ones, mental fatigue and fogginess, and anxiety. So remember, we're talking about all this stuff as a symptom of excess serotonin, can also be a symptom of excess acetylcholine. Ask your patients. Sometimes they're more willing to tell us than they are their medical doctors, which I wish wasn't the case. But ask them if they're taking any supplements, because sometimes they'll say, yeah, I read online that this is supposed to help me with my anxiety or my depression or my motivation, my mental clarity. Make sure to make a note of those and make sure that their attending physician is aware of what they're taking. There is an inverse relationship between serotonin and acetylcholine. So as acetylcholine goes up, serotonin goes down. So if we're increasing, and let's go back here, if somebody's taking an SSRI and increasing their serotonin, then they're going to have lower acetylcholine. Now, if the increase in serotonin lowers the acetylcholine to the point where it's releasing a good amount of norepinephrine and dopamine, then we've reached that happy balance. But if the serotonin gets too high and the acetylcholine gets too low, then potentially we could have some suppression of norepinephrine and dopamine, which is not good. We like dopamine. And norepinephrine is actually one of our motivation chemicals, so we don't want to get rid of that either. Insufficiency of acetylcholine, Alzheimer's and dementia, Parkinson's symptoms, impaired cognition, attention, and arousal. Cholinergic and GABAergic pathways, so acetylcholine and GABA, are connected in the brain and are responsible for helping us remember things, think clearly, and be motivated and awake. So if one of those symptoms or one of those neurotransmitters is out of whack, we're going to have a problem. So this is acetylcholine and GABA. Nutritional building block. This is a little bit more open. Meats, dairy, poultry. I like the fact that chocolate keeps coming up, but we don't want to encourage our clients to go out and start binging on Reese's Cups. When we're talking about chocolate, cocoa powder is a better substitute because it doesn't have all the fat in it. I personally put cocoa powder in my coffee all the time, but I'm sort of a chocolate fiend. Chocolate is not the best thing for people to use as a replacement because you have to eat so much of it to have any sort of notable impact, and nobody's going to eat half a cup of cocoa powder. And I'm talking the dark, unsweetened, unfattened cocoa powder. It's kind of bitter. But a little bit can help. Peanut butter, wheat germ, and Brussels sprouts and broccoli. And in response to a question, there are some blood tests to identify that have been used to identify neurotransmitter levels. So yes, there are some blood tests that have been used to identify that, but they are inefficient at best. It's better if they can talk with their doctor and be monitored very, very closely at the beginning. Getting a good psychosocial history and getting a good history of the development of the disorder will probably give the doc a better idea of where to start with these patients. So medications, cholinergics are used to treat glaucoma, bladder control, and severe muscle weakness. Glaucoma is one we hear about, but not as much as all of the commercials that advertise the bladder control medications. So remember, cholinergics are going to increase the amount of acetylcholine that's available. So going back here, if they already have too much, they may be having symptoms of depression, nightmares, mental fatigue, and anxiety. Combine that with medications meant to increase the acetylcholine, those symptoms may get worse. So medications that they're taking for disorders other than their mental health can have pretty significant mental health side effects that they just need to watch for. Anticholinergics may worsen things like gastroesophageal reflux disease. GERD, that sphincter that closes and keeps the stomach contents from coming back up, is weak. So if somebody's taking an anticholinergic, it may make that muscle not tighten quite as much. Anticholinergics are used for extrapyramidal symptoms in schizophrenia. So when you have a client who has restlessness, agitation, we will have occasionally clients who are taking antipsychotics or atypical antipsychotics, and they will be restless. They'll switch from one side of the seat to the other. They'll be jittery, agitated. They may or may not have muscle spasms, may or may not have drug-induced Parkinsonism, and tardive dyskinesia, the involuntary muscle movements in the lower face and distal extremities, the ones that we always associate with high levels of antipsychotic medication, with people smacking their lips, tongue movements, finger movements, those sorts of things. So all of these may be addressed with anticholinergics, but we're getting to the caveat here. Some of your anticholinergics are atropine, Cogentin. I know I've worked with patients who've been on Cogentin before. Chlortrimeton. That's one of those antihistamines that we hear about. Thinking about that, and patients who were taking over-the-counter medications, not even thinking that it will impact their prescription medications. Dimenhydramine or Dramamine. So if you've got somebody who's got, I personally get movement sick pretty much everywhere. I'm not the fun person to have in the car. But if somebody takes Dramamine, it may have some significant mood side effects. I know when I take Dramamine, I get really, really depressed, not just lethargic, but again, I'm even less fun to be around than when I'm sick. Diphenhydramine. If you look on the side of NyQuil, if you look on the side of any of your, quote, sleep medications like Sominex or Advil PM or Unisom, Benadryl PM, Tylenol PM, they have diphenhydramine in them. This is Benadryl. Benadryl is a mild anticholinergic. Hydroxyzine. I haven't seen Atarax, but I do see Vistaril quite a bit. I do see Wellbutrin and Zyban quite a bit. And dextromethorphan. I'm going to go off on a little tangent on dextromethorphan right now, because not only is it one of those drugs that's in most cough preparations and most cold preparations that people use, and it may be contraindicated with the meds they're on, but youth have figured out that you can take dextromethorphan rectally, and it is directly absorbed into the bloodstream a lot faster than orally, and it's got the anticholinergic effects, gives them a buzz. So be aware, dextromethorphan, is starting to become one of those that's abused. So think about if you've got a client. I mean, it wouldn't be uncommon for me to see clients that are on Zyban. They've got a cold, they're taking dextromethorphan and diphenhydramine, and maybe they've also got allergies and they're taking chlortrimeton. So you can see where we're kind of doubling up here, because you think Benadryl is an antihistamine, dextromethorphan is a cough suppressant, so they wouldn't work in concert with one another, when actually they kind of do. So encourage your clients to take it seriously when the docs say, what over-the-counter medications and what supplements are you taking, because they can have a significant effect on prescription medications. Anticholinergic drugs are used to treat a variety of conditions, from gastrointestinal disorders to genitourinary disorders and respiratory disorders. A lot of our clients have those. Being aware of what they're taking for these disorders and what they're taking for their mental health is important. I know I've beat that one into the ground at this point. So one last little thing on homeostasis, because you know that I totally love how the body tries to protect itself and maintain homeostasis. Higher acetylcholine and norepinephrine, so your ACH and NE, with low serotonin, so high acetylcholine, high norepinephrine, low serotonin, produces anxiety, emotional lability, irritability, anger, aggressiveness, rumination, impatience, and impulsiveness. That describes most people I see. It does not necessarily mean that they exclusively have a serotonin imbalance, or this always describes them. But it's interesting to see what happens when you start changing the balance of these neurotransmitters. When norepinephrine, dopamine, and serotonin are low, that's just bad, and acetylcholine is high, the result is, for lack of a better explanation, simply depression. And increasing serotonin lowers acetylcholine, we talked about that earlier, but it also lowers norepinephrine and dopamine. So as one increases, these other three go down. You're upsetting the apple truck, if you will. We need to make sure that things are in balance. It's important to remember that it's not necessarily always about increasing something. Too often as a society, our first thought is, we don't have enough, fill in the blank, so I need to get more, fill in the blank. Sometimes it's that you got too much and it's causing everything else to be suppressed, which is why it's really helpful for patients to keep a food diary, chart out their moods, chart out what happens when they take their medications. And we can make it pretty simple as clinicians. We can give them charts where they're just checking boxes, so it's not taking 20 minutes 4 times a day. But it's really helpful to be able to look at patterns, see whether there are certain patterns that have to do, obviously, with work, with sleep time, with nutrition, with number of hours of daylight, anything that might be impacting it, in addition to looking at how it came on, and when they start taking a medication, what happens to their symptoms, both immediately and over 4 to 6 weeks. So there are a variety of different neurotransmitters involved in addiction and mental health disorders. It's not always about increasing a neurotransmitter. Sometimes you need to decrease it. The human brain tries to maintain homeostasis because too much or too little of anything can be bad. Whether it's water or dopamine, too much or too little can be bad. A balanced diet will provide the brain the necessary nutrients in synergistic combinations that will help it have the building blocks it needs. And what it doesn't need, it'll just excrete. So there are several slides worth of resources that you can go back and look at. if you have questions or if you're really interested in this. A couple of them that I found really interesting were on diet soda and aspartame consumption. Looking at the inositol chemical, or not chemical, but nutrient, biofactors, looking at GABA, and then that textbook I told you about that talked about neuropsychopharmacology. It is free, it is online, it is available. It is not the most exciting read in the world, but if you're fascinated by the way things work in the brain like I am, you might find it interesting reading, when you're on the train on the way to work or whatever the case may be. So, in response to your question earlier about the blood tests, I will find the references that I was looking at when I made this class, and I will message you with them in the next couple of hours, so you have information on ways we can test and what we can and cannot do with as far as determining in a live patient their level of neurotransmitters. Any other questions? Okay. Let's see, I stopped the share.